Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon and welcome to VITALS. My name is John Langell. I'm the president of Northeast Ohio Medical University, and I'm pleased to kick off VITALS for 2023 with an outstanding speaker. VITALS is intended to be an open forum to hear from America's healthcare leaders and to engage in meaningful dialogue with them and to learn from them. Today, I'm pleased to welcome Jonathan Lee, founder and CEO of Signature Health, a federally qualified health center providing care to those in need across Northeast Ohio. Mr. Lee struggled with substance abuse as a teen, but thankfully found recovery at the age of 17. Motivated by his life experiences, in 1993, he opened North Coast Center, which focused on treating adolescents for substance abuse disorder and later became Signature Health. Since then, Mr. Lee has grown Signature Health into a full-service healthcare agency that offers mental health, addiction recovery, primary care, infectious disease, pharmacy, and lab services to patients through Northeast Ohio. Please welcome Mr. Lee. Mr. Lee, the floor is yours.
Oh, John, I really appreciate that really warm introduction. That was so kind of you. And it is such an honor to be here with all of you here with NeoMed in such a long string of distinguished speakers. I'm not quite sure that I'll be able to meet the same level of stature, but I certainly am interested in talking a good bit today about integrating primary care and behavioral health care, which is something that we've been working on here at Signature Health for quite a bit of time. First, let me stop quickly and just say to everyone listening and watching today that I am a little bit under the weather, so if my voice sounds strained, that's why, but we're going to power through here because this is really such an important topic to me. As we talked about here in the introduction, I am a recovering person, and so this is something that is very near and dear to my heart as well as my vocation. But I think what's even more important is as we think about where behavioral health touches the rest of medicine. So when we look at this, if you look at the top 5 most expensive patients in the healthcare system, roughly the estimates are about a third of those most expensive people are what we would call the really acute costs. It's this an acute one-time event where you're in that top 5, but you're not likely to repeat that next year. This is something that is usually happens to younger people, etc. Then there's a third of that 5% that are chronically expensive. Often this is heart failure patients that are in the hospital quite a bit. We do expect this to be expensive, and we do expect it to be expensive for a long period of time. And then there's another third, the last third, that I really want to focus on, which are folks with a number of chronic conditions, but are preventable and treatable, and we can make some intervention. And why are we focused here? Well, these top 5%, many of you probably know, cost the healthcare system about 50% of the spend every year. So that 5% of patients costs 50%, And about a third of them, we feel like we can probably do some things to intervene on the amount of healthcare services that they're receiving in a year. When you really drill in and look at those folks, the vast majority of them have substance use disorder or a mental illness or both in that list of chronic conditions. And it interacts with all of the other chronic conditions that they're often challenged with: hypertension, diabetes, so on and so forth. So if we want to take a preventative approach with these folks, it's intuitive. It makes sense that we really need to address the mental health issues that are going on, substance use disorder issues going on, or we're just not going to make a whole lot of progress in the healthcare costs, not to mention the lifestyle and the outcomes for these patients. So how do we tackle this? And that's something that we've been working on here at Signature for some time. Medicine is obviously siloed because of the specialties and the immense amount of knowledge that physicians and other clinicians need to learn and master in order to be effective. And so there's just simply no way for any one person to know all of the specialty areas. So we have to silo in that way. But there is a particularly wide gap between behavioral health and primary care, or more broadly, behavioral health and the rest of medicine. I would say a larger gap than perhaps between any other specialty. Well, why? Why is that there is a particularly wide gap there in the siloing here that we really need to address in order to bring these costs down, et cetera? And I would argue that one of the reasons for that is what I would call a professional stigma. And so we have a number of very learned professionals, physicians, students, medical students, nursing students, pharmacy students here on this program. So if you'll indulge me for a minute, let's do an entirely let's do a thought experiment here. This is not terribly scientific, but I think it will illustrate my point. So even though this is Zoom and I can't see if you're going to actually do this, I'm going to invite you to just close your eyes for a second. Just close your eyes and let me paint you a mental picture. Think about this. A 46-year-old Caucasian female who is about 5'3", weighs 180 pounds, presents for a routine appointment at her physician's office along with her sister. Shortly after the patient is roomed, the physician enters the exam room and is able to observe fairly quickly that the patient is slurring her words, had trouble balancing, and appears to have an altered mental state. The physician quickly decides that this patient needs to go to the emergency room, explains to the sister that there's a need for emergent care, and arranges for emergency transport over to the local emergency department. We have that in your mind's eye. Now, the outcome was that the patient at the emergency department was given Ativan and released without any labs being drawn or imaging being done. So think about that. And I want you to stop and notice how you feel about that as a clinician or as someone who's been in the healthcare field, and think about, what kind of questions you have, what kinds of things you would have done differently, it just kind of doesn't make sense. So let me take it one step further. We'll go on just a little bit here. Let me add a few more details. So that same 46-year-old Caucasian female, 5'3", 180 pounds, who has a diagnosis of schizoaffective disorder and a history of frequent hospitalizations, is prescribed lithium, presents for that same physician visit with her sister. Same thing happens. The physician notices slurred speech, inability to balance well, and an altered mental state. The same physician decides that this is an urgent matter, talks to the sister, and arranges emergency transport to the emergency department. And now that same outcome of the patient was given Ativan and released without labs being drawn or imaging being done. And what I'd like to invite you to think about is when I added in the detail about a schizoaffective disorder, frequent hospitalizations, and lithium, did you for 1 second in your mind kind of think that the outcome was maybe a little bit more understandable? A little bit more, oh, the emergency department knows this lady, and perhaps they knew what they were doing when they gave her Ativan and sent her on her way. Now, if you actually did follow my instructions and close your eyes, go ahead and open your eyes back up and just ask yourself those questions. By the way, what you should know about that case that I just gave you is that this is an actual patient here at Signature Health. And that patient, fortunately, when they were released from the emergency department, returned to our office. And the physician ended up arranging for a second set of emergency transport to a different emergency department where they actually did do the blood labs. The patient was experiencing acute lithium toxicity, which was certainly life-threatening and needed to be inpatient admitted. And so, sure enough, that second emergency department did admit that patient urgently for the lithium toxicity and treated her. If she had passed away, the autopsy would have said that she died of lithium toxicity. But the reality is, in my view, that what really happened was a bit of professional stigma because somebody in that emergency department decided that, oh, we've seen her and we're not going to listen and we're not going to pay attention. We kind of roll our eyes. One more of those mental health patients, one more of those addiction patients, one more of those opioid overdoses. Here we go in the emergency room again. And I wish that this was an ancient case, that we no longer do this, but unfortunately it still happens. So I just want you to think about that a little bit. I had a conversation with an OBGYN, for example, and I asked her if she routinely screens her new pregnant moms for opioid use disorder because of the risk of neonatal abstinence syndrome. In which the surprising answer was, well, Jonathan, we don't know what to do with those patients or have the wherewithal to treat those patients. And we're concerned about the liability if we do a urine screen, a toxicology screen on that patient. To me, that is stigma. That is professional stigma that if it were anywhere else in healthcare, we would simply be outraged and we would be filing lawsuits. But somehow it seems to be okay in behavioral health. So that is one important area that we have to focus on, is that stigma. And the second gap that we have to focus on in order to make progress here is that there's huge operational differences between behavioral health and primary care. And oftentimes those things have a hard time meshing. So here at Signature Health, what we've been doing is a couple of things. We've been working on integrating behavioral health into primary care. And that's going really well. And I think there's probably a lot of experience out there in the country these days with this kind of thing. So this is the idea where you hire a behavioral health consultant, usually a social worker or a licensed professional counselor, and they work with right hand in hand in the exam room when necessary, right in the primary care workspace. And then there's hot handoffs. And then that behavioral health person, they can help keep the physician moving, if you will, or the nurse practitioner moving, and they address the behavioral health needs, short-term kinds of issues that they can take care of there in the primary care office. This goes really, really well. You have to have the right kind of social worker to do that, but there's a lot of experience, and happy to take questions later if people want to know more about how we do that. What's a little harder is the other way around. and that is taking primary care and integrating it into behavioral health. And what we found is that there's a lot of co-location that happens here, but we've had to be a little bit more creative. And that's the invitation I want to make to all of you, is to think about this space, try to move past your stigma, and then try to get creative. So how is it that we've been creative? For example, I'm really proud of my infectious disease team who worked with behavioral health. We now have universal opt-out screening for hepatitis C for our patients that are coming for a diagnostic assessment. So you're a new patient to Signature Health, you're coming for a behavioral health reason, and we're going to do a blood test, which is very unusual for most behavioral health organizations. But we're going to order a blood test, and we're going to screen you for hepatitis C and HIV. And thank God, because what we found is, particularly for our substance use disorder patients, approximately a third of them are positive for hepatitis C. And so they're in a situation where their liver is at risk potentially from this virus, and it's curable, and they don't know that they have it. But we're able to find it and identify it and put together a treatment plan. Now it's interesting because when you're talking about behavioral health patients, you have to go a step further than just, oh, we did a blood test and we identified this. Often what happens with hepatitis C is that you get referred to go get a liver biopsy or a FibroScan. And there are only, as far as I know, there's only 3 FibroScan machines in the city of Cleveland outside of Signature Health. And those are at the 3 major hospitals, Metro, Cleveland Clinic, and University Hospitals. I believe that each of them only has 1 FibroScan. And these are machines that make that you don't have to do a liver biopsy, which is a somewhat painful procedure. This is more like an ultrasound of your liver. We had to get a FibroScan machines in order to make that happen, so that we could make sure that not only did we identify it, we could put together a treatment plan. One additional project I want to talk to you about in terms of integrating, another thing I'm really proud of my team. So we do universal opt-out screening like we talked about. We've got those FibroScan machines, and then we're also putting behavioral health into primary care. But the other one is really, again, pretty unique, is we're about to open a medically enhanced residential treatment program. So this is for patients who are often suffering from an opioid use disorder. They use an unclean, unsterile technique and inject bacteria into their bloodstream. And that bacteria then goes to their heart, and they end up with infectious endocarditis and need cardiac surgery often. And certainly they need antimicrobial therapy. So we have very, very, very sick patients who've just had a major heart surgery, need long-term 6 weeks of IV antibiotics. And there they are in the hospital, and the hospital has a difficult time discharging them. Why? This gets back to professional stigma. So they can find nursing homes that will take care of hanging the IVs for the antibiotics, but they cannot find nursing homes who will also provide Suboxone or Vivitrol and other medication-assisted treatment modalities, as well as the therapy needed for substance use disorder. Now, I have to blame my behavioral health colleagues too, because you can also find a lot of treatment centers who will take care of the Suboxone and will also provide all of the counseling, but they won't hang the IVs. And so what we're interested in doing, and we're just about to launch here at Signature Health, is medically enhanced residential treatment program, where we are able to both take care of the IV antibiotics, as well as provide the substance use disorder treatment, both the counseling as well as medication management, et cetera, at the same time for the same patient. So we completely integrate that care and wrap that around. So I think that those are some examples of what we've been working on that are really pretty innovative, and a way that we can have enormous impacts on the outcomes for these patients, and in a way that is patient-centered and really helps people live their full potential. So with those examples and just a highlight of the gaps, one is the professional stigma gap, and two is the operational difference kind of gap between behavioral health and the rest of medicine. I guess I'd like to close with this thought, which is if we can tackle that professional stigma and insist on improvement, and people are really interested in paying close attention, I think that we can move the needle in a lot of other ways in this area of integrating behavioral health and primary care. And I think that the cost of very, very expensive patients like this is making this a focal point for so many payers, for Medicare, and for large health systems that are going at risk. So this is an area that I think is really important that we move the needle on because there's a lot of return on our investment. So with that, I see my time for the typical medical appointment is up. I'd like to bring my friend Monica Robbins into the conversation. Virtually everyone knows Monica from WKYC, and she's the senior health reporter there. So just really excited to have this conversation with you, Monica. Thank you so much for joining me here today.
Jonathan, thank you so much, and welcome to all of our participants. We have about 63 people in here, so if you have any questions after what you heard from this presentation, please put them in the Q&A, and I'm happy to ask. I personally have a question. We obviously have a mental health crisis happening across the nation here in Northeast Ohio as well, and there was a recent survey done where it just showed we just don't have enough beds. So I understand Signature Health is opening a new place, but from your perspective, what do we need? And at the same time, when we have a workforce crisis with behavioral health professionals, how do we address that first?
So I actually think I'll take the question in two different parts. So I actually think that the workforce issue is going to be a harder issue to address than the beds. Beds are just a matter of capital and investment. And I think many of the folks who run inpatient units around Ohio will tell you that they actually do have beds available. What there is often is a mismatch between the payers and the beds. So Medicare and Medicaid will, it's a long-standing rules that there are only certain type of psychiatric beds that they will pay for, usually those that are attached to large hospital systems and not so much the freestanding ones. So here are freestanding psychiatric facilities and substance use facilities that would love to take care of patients that are covered by Medicare or Medicaid, and there's some statutory problems that prevent that. That's really a matter of policy and money. And when Congress decides to make the change to those rules, then we'll see some relief there. Congress just recently made some significant changes in the omnibus budget bill in December, allowing more classes of mental health counselors to see Medicare patients. So this is certainly on their radar screen, and I expect them to continue to address it because they know that it is a crisis in the country. The workforce issue, a little bit of a different story, and that's because what we're finding, of course, is a lot of our baby boom professionals are retiring, and they're just not being replaced as quickly at the same time that we have exploding demand. I'm honored to be invited to be on the workforce committee that the State Department of Mental Health is kicking off next week at the governor's direction to look at this issue statewide in Ohio. And so I'm hopeful that that work will bear some fruit. We know that we have to get more people interested in this field. We know that there needs to be reasonable wages that are paid so that people find this work that is comparable to other work that they might choose. And we also know that there's a lot of support that we can provide to get people through the training and degree work, so on and so forth. So really looking forward to that, but I do think it's a longer term kind of chronic problem that's going to take some time.
One of our participants asks, how did you get introduced or become a substance user, and how did you recover?
So like many people, the introduction for me was simply through friends and at school. There were a number of people that had made those decisions, and I was a young man. I was, I was 14. I was a boy. Um, Obviously, when you're young like that and impulsive, you don't make the best decisions. There's also a heck of a lot of mental health and addiction challenges in my family. So I don't know if coming from that contributed, but to that initial decision. But once I made the decision, there was really no looking back. Recovery was an amazing gift by the assistant principal at Brush High School in South Dakota Lyndhurst School District, who recognized that I had an issue and confronted me. And when I admitted to him that I had been using, he then helped me get into treatment. At the time, I was at St. Luke's Hospital, which has since closed. I was at St. Luke's Hospital for about a month and then went to New Directions for about 4 or 5 months, and was able to find recovery at 17 years old. And so it's really been an amazing journey since that time to not only grow in my own recovery, but then also to try to help other people find it as well.
Rod asks, do you think our country's mental health has gotten worse over the past few years, or is it symbolic of the times we're in, or a reflection of where we've always been, but now there is heightened awareness?
So I do think that it has gotten worse. And I think it was exacerbated by the pandemic. Human beings are social creatures. We need connection. We need uh, community and fellowship and time with people. And when we don't have that, it's quite clear. I mean, this is essentially the punishment that we put people through in terms of being in prison. We know that when you isolate for a long time, for many people, it has disastrous effects. Not everyone, but for many people, disastrous effects on your happiness, your mental health, etc. And so we think that because of the isolation that occurred, that's really brought this out. The uneasiness or the not knowing has really impacted our children. Young people look to adults for their cues about the stability of the world and whether or not they should worry. And we know that the cues that they were getting were not so sure from adults. So we saw skyrocketing rates of teen and preteen anxiety disorders, so on and so forth. So I do think in that way it has gotten worse. There is also an element, of course, of the stigma is going down. And so people are talking about it more, and people are getting more help. And because of that, it is also bringing people out of the woodwork that maybe previously wouldn't have talked about it.
One of our participants asked, why is funding and reimbursement more widely available for physical disease and treatment rather than mental health?
Why? I think that's a great question. And I would go back to my original point about professional stigma. There is also, the truth is as well that interventions for mental health are generally less expensive. So pretty much the tools that we have are either medications or counseling. There is some ECT. We do see some magnetic stimulation kinds of machines that are coming out recently, but for the most part, it's either medications or therapy or both. Those are not terribly expensive in comparison to MRI machines or doing a surgery or procedure. Those are extraordinarily expensive. And so that's a part of it. But also the funding. For years, behavioral health was funded differently and separately. You'll notice we have an Ohio Department of Mental Health. We have a whole separate mental health department, separate from the Department of Health. So there's been this separation for years, and it it really boils down to back in the days when we used to institutionalize people, put them in an insane asylum and kind of lock them away. Not understanding the disorder has led to thinking of it as somehow people are morally bankrupt or stained. And we're going generation by generation. That's getting better and better, but we're still working on that. And that trickles right into the payment and reimbursement. I can tell you that the rates reimbursed for a psychiatrist are far less than for an attorney. And so it amazes me what is passed off as adequate reimbursement in this day and age.
Another question from our gallery. If a behavioral health organization is not in a position to co-locate with a primary care provider, how can the organization best coordinate services with providers in that community?
So my answer to this really is focus. And the reason why I say that is because when we co-locate, we have been able to focus. And so if you're unable to co-locate, having a person, a designated point person whose job it is to do that coordination is critical. If you add this on to somebody else's job, it will always kind of fall to the wayside because communication is difficult. Even when you connect with somebody, you may not actually communicate well. So it really takes follow-up, and it takes repetition, and it takes dedication. So my number one recommendation is appoint somebody, whether it's a nurse or an LPN or someone that's got a good clinical eye, keep an eye on what needs to be communicated and make sure that that happens continuously. I would also recommend, if you have the ability, to partner with one of the major hospital systems, to use Epic or something like that, so that you have an electronic health record that is got some built-in interoperability with other health systems, because that helps with the communication.
From our gallery, what would you say is your leadership style and how did you develop it?
Wow, that's a really interesting question. So I would call it a participatory leadership style. I have a team here of 7 people that I rely on heavily. And what I like to do is see if we can get to consensus. And then ultimately, if we can't get to consensus, then I call the ball. And I think that that's really important because as a leader, it is my job, frankly, to get out of the way and to give really, really sharp people that I work with, give them the ball and let them run with it and shine, and give them the platform to do that, and perhaps some coaching. Usually they don't need much, but that's my job, is just to kind of set the environment and then let them shine.
What advice do you have for us, both working at a medical school and in our professional lives, to better make people aware of mental health, treatment options, and reducing the stigma?
That's a pretty broad question. So I think that, one, reducing your own stigma means spending some time intentionally in behavioral health, and having those conversations with people in the specialty area, and making sure that you're doing your homework, because all too often this is the area that people skip over or don't pay as close attention to. And so that's really, really important. I think that you can be a good role model for other people. And I think if we continue to shine a spotlight on the existence of stigma, and in many ways, this is kind of like the realization that people are coming to around structural racism, where we know that if we focus on it, and we start to look at the pieces that have become institutionalized or structuralized, that we can then start to make different choices and have different conversations. It's the same kind of thing, where this has become institutionalized in our payment systems, in the design of an emergency room, for example, that we just need to look at and start making new decisions.
This next question is quite interesting because we're right in the middle of an opioid epidemic, and now legalized gambling just came into play. So what impact do you think legalized sports betting will have on gambling addiction and other addictions in Ohio?
Well, the obvious thing is that it makes gambling so much more socially acceptable and so much more widespread and so much easier to access. So for people who uh, are developing or have developed an addiction, uh, this is akin to legalizing drugs or legalizing alcohol. If you have an addiction, you're going to do it even if it's illegal. And so I don't know that it's just suddenly now going to make you do it more. It just makes it easier. Um, but what it will do is take a lot of people who maybe otherwise would not have been involved in gambling at all, or certainly not in a problematic way. And because you kind of make it more socially acceptable, and it's at the Rocket Mortgage Fieldhouse, for example, it's the way that people start, and that's sometimes leads to um, really tragic outcomes. So that's my concern is that there's more access, and that it's going to be more prevalent, and that will then increase the number of people who really suffer from that addiction.
Is Signature Health starting anything relating to sports betting or online gambling at this point, or do you already have something in place?
We have a new gambling addiction program. I'm really proud of my team in our Maple Heights location who have taken this on as their mission. So we now have, it's either 3 or 4 certified gambling addiction counselors out of that location. Ken Holt is the supervisor that leads that team. And so we do have the beginning of that capability. We know that there's a whole lot more that we need to learn and grow and do to be able to impact that addiction as well.
Is there such a thing as perfect mental health, or do we all have some type of condition?
So that's the one thing about stigma and mental health that I really want to be careful about, which is people have emotions, and you will have days when you have difficult emotions. You'll have a lot of stress. You'll have grief reactions, etc. That's all in the range of normal. And just like you can either be someone who exercises physically or someone who doesn't exercise, practicing good mental health habits is really important for everyone. When it becomes an illness, is really a fairly defined situation. And so just because someone has a particularly difficult day or a string of days doesn't necessarily make them mentally ill. And so I want to be careful that people don't overdiagnose themselves, that we really are focused on people who have a diagnosable kind of condition. But we do know that it's often underdiagnosed, and that there are a lot of people that do have conditions out there. So practice good mental health. What does that mean? That means spending time with family and friends. That means paying attention to your spirituality. That means eating well, getting good amount of sleep, and making sure that you exercise and get outside, because those things all contribute to our mental health.
As a non-doctor, what have you learned about communicating with doctors or those in the medical field as opposed to those not familiar with medicine?
I'm not 100% sure I understand the question, but what I would say is there is a internal divide. I shouldn't say a divide, but there is certainly a difference between our clinicians who are counselors or social workers, marriage and family therapists, versus our clinicians who are medically trained, like our nurse practitioners and our physicians. because they are much more interested, meaning the medically trained folks are much more interested in all of the body systems, in the making an evaluation about the impact of medications that they might be introducing, so on and so forth. So their focus is different, as opposed to the focus on biopsychosocial kinds of things like our counselors would be. So it's important to keep the audience in mind. It's important to understand that the focus is different, and that each discipline brings a really important piece, because virtually all the research for most disorders will tell you that, or the most prevalent disorders will tell you that a combination of medication and therapy is always is usually the most effective, not one or the other. And so bringing both of those perspectives is really important as a part of our clinical teams.
You talked a lot about stigma, and unconscious bias is another thing. What's your advice to these medical students relating to how do you realize what you're doing? How do you self-check, and what questions should you be asking yourself?
There's a relatively well-known bias checker that you can access for free on the internet around racial bias. And if you haven't done it, I would encourage you to do it. It takes about 5 or 10 minutes, and it helps you to identify kind of natural biases that you have around race. It is also instructive or helpful to go through that experience so that you understand that you have biases in all kinds of areas. It's the way our brain works. We can't nearly process all of the information that comes at us in a day. So we put things in our mental buckets. And when I put something in its mental bucket, then I don't really have to think carefully about that thing or really observe that thing. And sometimes those buckets don't serve us well. And that's really what's important, is to realize, okay, why is it that that thought went through my brain about that person or about that presentation? Just like I talked about in my sample case, when you have somebody that walks in the door and you've put them in your mental bucket that, oh, that's a mentally ill patient and they're just here again one more time, I got to give them some Ativan and calm them down. What happened in that situation is that that mental bucket didn't help that patient, because that patient was having a real serious issue with medication toxicity. So the important thing here is to identify your buckets and to be conscious of when you're using them, and to make the concerted effort to not be so quick to judge, if you will.
This participant thanks you for what you said about overdiagnosing and wants to know what policies or practices have been implemented to support mental well-being of the staff at Signature Health.
So, one of the most important values that I have is people first. And obviously our staff is really, really important because without them, we cannot help. And so this has really been crucial. So for example, making sure that our staff have just as much access to their own mental health therapy as we would want for anyone else. So incorporating the access to on-demand, whether it be virtual, et cetera. What I find is that in addition to those kinds of benefit things that many organizations will do in the HR department, really what's the most important is listening, having direct conversations with people, understanding them, understanding where they're coming from, and providing teamwork, camaraderie, community. There was nothing better for our mental health this year than to have our office Christmas parties. And so it's from things like what seem as trivial as that, all the way up to as formal as having an employee assistance program and everything in between. So this is something I think about quite a bit in each and every day. What I love is through my advisory council, I have a group that I meet with at each of our locations. They provide me a lot of feedback about what they see, what is needed, and it comes directly to me without any steps involved, so that I feel like I have a really good sense of where people are and how they're feeling.
Can you talk about the difference between a federally qualified health center and other health centers?
Yeah, absolutely. So federally qualified health centers, there are 1,400 of them in the United States. And we collectively serve about 1 out of every 8 people in the United States. Uh, the vast majority are indigent or low income, so under 200% of poverty or below. So as you can imagine, it's a very, very large system. Um, Here in the Cleveland area, my colleagues are the Centers for Families and Children, Neighborhood Family Practice, uh, uh, Care Alliance, and Access Point, as well as Asia Inc. So there's about a half a dozen of us here in the Cleveland area. And we get some federal dollars to be able to provide indigent care and to make sure that we're able to provide our services on the sliding scale. So we don't turn people away. And we have primary care. Some of us also have behavioral health care, obviously Signature does, but also other service lines. So for example, Signature is about to launch dental care in our Painesville location in another 3 months or so. So we are a front door to the healthcare system for many, many Americans.
Can you talk about, thanks to the pandemic, obviously telehealth became very busy. What were the takeaways from switching Signature health appointments from in-person to telehealth, in your opinion?
So what we saw was an enormous spike, particularly in behavioral health, but even primary care, et cetera, an enormous spike in telemedicine utilization. And then we've seen it drift down from that peak. And right now it's hovering around 50-50. And we expect it to continue to trend lower. Will it go all the way back to zero? Absolutely not. My expectation is probably around 40 or 45% of what we do will remain virtual. So this is obviously a really important tool for people to be able to access care, much more efficient, so on and so forth. But we also know that there is real value in coming in to seeing their clinician in person. And so we expect that we'll be in a hybrid world going forward. And I don't really expect that to change.
From our gallery, your childhood story, while tragic, is one of resilience and thus helpful to those who have also experienced some horrific things. Can you offer some words of wisdom to health professionals who treat those who've had similar experiences?
So when you say treat those who have had similar experiences, if you're saying similar experiences to me, the most important thing is to try to take the extra minute to listen and to be empathetic, because all too often we get moving too quickly, and people like me need that connection. If you're saying that, if you're mentioning that the clinician themselves has the same type of issues or the same kind of history as their patient, what I would say is, dare to care and dare to reach out, because your experience can be powerful. I can't tell you how many times people have said, thank you so much for sharing. I was too afraid to share myself. Thank you so much for sharing. I really needed to hear your example to help me. And so that's why I'm very open about it, is because it was recovery was a gift. And sometimes it's just something as small as that can impact somebody else's life.
Obviously, we talked about the shortage in mental health providers at Neomed. They recently introduced the concept of a certified mental health assistant, which is a graduate level physician extender in mental health treatment. If approved at the state level, it would be the first in the country. In addition to this and the integration with primary care, what else can be done to alleviate this mental health professional shortage?
So that innovation will obviously help impact the need for additional providers who can prescribe medications. So my hope is that Neomed and other organizations of higher education would consider expanding their programs for social work and counseling, because what we find, particularly with social work, is that there simply are not enough seats around the state of Ohio. There's a number of regulatory and accreditation reasons that make those difficult programs to stand up. I get that, but we really do need the workforce. And so having the available seats, particularly in social work, but counseling as well, would be really, really helpful.
And another aspect, perhaps I'm sure not unique to Ohio, but like you mentioned, there's a lot of schooling people need to become a licensed professional counselor. Is all obviously that's needed for legitimacy and a host of other reasons, but there's also the aspect of livable wage. I was just doing a Google search, and school counselors are actually the highest paid at just $57,000 a year on average.
Mhm.
That kind of money is not going to inspire anybody to get into this field. So if you had the carte blanche to make a program, what would you advise? What would you think would be the best way to really get the fire going and get more people into this field?
So I say this all the time, which is the unfortunate truth that half of everyone's paycheck is in their heart because they really deserve to make double what they are getting paid. And that is directly from reimbursement rates and so on and so forth. So if I had a magic wand, of course, we would raise rates. But I also think that it's important for us to be good stewards of the dollars that we're talking about, and to make sure that those get utilized efficiently and in a targeted way. So there is some operational waste in the system that we could be more efficient with the resources that we have. Um, but I do think that it's really, really important to look at some of the reimbursement and wage kinds of issues. However, if you do have somebody that is interested, there is still quite a barrier to getting all of that schooling. It takes a long time. Fortunately, as a federally qualified health center, there are some federal tuition reimbursement programs where people can basically get their loans forgiven over the course of usually a 4-year work commitment. So you work at a federally qualified health center, and the loans are forgiven over that period of time. And so that's a nice bonus for working here if someone wants to get started in the field, because that certainly adds to that base wage quite a bit when you're knocking out quite a bit of their student loan debt.
We're just about wrapping up our hour. So if there are no more questions from our gallery, I will ask you your final thoughts. What message do you have to inspire our students moving forward, and anyone else? And wait, one more question that just came in. And this is my favorite question of the day. Is social media bad for mental health?
Yes,
The
it
easiest
absolutely
answer.
it absolutely is, simply because, one, I'm sure all of you have noticed, uh, social media companies are very, very good at getting you addicted to your phone. I would simply challenge you to not be on social media for a week. There's a lot of people that have a hard time with that. So they're very, very good at it. Two, it brings an enormous amount of stressful information to you on a constant basis. And so take a phone break if you can, because it really is. And there is even internal studies at Facebook that knows that Facebook has a particularly detrimental effect on young females. So when you think about people going through adolescence and their body image issues and all the rest, very, very difficult time. So my short answer is yes, it is definitely bad for our mental health. And frankly, I think it should come with a Surgeon General warning.
All right, final thoughts. What would you like to leave our students with?
My final thought is all of you are at the beginning of your career, or many of you at the beginning of your career, and there's a whole lot of decisions that you can, directions that you can take. Regardless of what specialty area or where in medicine, you are going to come into contact with people struggling with mental illness and addiction. And I want you to just take a minute to remember to treat that patient the way you would want to be treated if this was you on the other side of the stethoscope.
Great insight, Jonathan Lee. Thank you so much. And thank you to all of our participants. Make sure, we're kicking off 2023 VITALS series. Make sure you join us next month. I believe, if I'm not mistaken, it is February 2nd will be our next segment, but check your calendar. I'm probably wrong. So have a great day, everyone. Jonathan, thank you so much again.
Thanks,
and thanks for joining us. Have a great day, everyone.
You too. Take care.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.